All right, good afternoon. Just let's start because we only have 15 minutes. I'm very delighted to be invited to this webinar. I think it's a very important topic, the peri-implant diseases we have around our implants or even around teeth. So Victoria Simpson, thank you for your very kind and interesting lecture. It's always nice to have a native English speaker to listen to. It's very nice on the ears. All right, I would like to talk to you about the beneficial effect of oxygen on dental surgery. Let's see if it's working. No. There we go. Well, I have my private practice in Bussum, that's the Netherlands, and I'm graduated in Amsterdam in 2008. And after a few years, I did a postgraduate program in Nijmegen, that's near the German border, where I mainly specialized in implants and restorative dentistry, and I'm recognized as a specialist in this field. And besides the work I do in the clinic, I have a passion for photography and dentistry. And in a few years, I just started to use these pictures for clinical lectures and publications. Before the COVID time, I was very busy with lecturing all over. So that was a very nice hobby. And at this moment, we're all condemned to the webinars, but it's a little bit less fun, but we can still proceed with each other to talk about dentistry. Besides my work in my private practice, lecturing, and also being an author and editor for magazines, I also started with my own private implants academy. And so 2 years ago, we started with a nice group who had come for 8 full days to learn about implants. So let's talk about Blue M. Normally I have a longer lecture, but let me see, I want to remove my face, that's better. Normally I have a longer lecture about gingivitis, periodontitis, perimucositis and wound healing, and what especially this oxygenated product does on these diseases. But since the time, I will just keep it under 15 minutes. I will mainly talk about the effect of this oxygenated products on inflammations around implants. So this is the product. It's like a gel with a lot of oxygen inside. And as you can see around this healing abutment, you see the bubbles, and that's the oxygen where we have around these oxygenated products. So the active ingredients of the Blue M are sodium perborate, honey, and xylitol. And you may think honey is that sugar. No, it's just the active ingredient which releases oxygen when it comes in contact with the saliva. And some other ingredients are methylsilicates and lactoferrin. So it comes in a toothpaste, mouthwash, and oral gel. And I find it in my private practice very useful for my patients because I'm not a big fan of the chlorhexidine products. And I see in my clinical cases almost the same tissue response around of the soft tissue when my patients rinse with the Blue M mouthwash instead of the chlorhexidine. And if you have the oral gel, it has even a larger release of active oxygen. So it's a product which started a few years ago, and we see a lot of in the clinical cases around the world of many famous doctors, we see them using these Blue M gels, and that's something I think is clinically proven. The evidence is now coming. They're investing a lot in the research at this moment. So we've got some very nice evidence articles coming up, more in vivo and in vitro researches on the effect of these kind of products. So I want to this afternoon just talk on a few cases on how it might work. You might recognize cases like this you might have in your private practice. We do a lot of work to restore a lateral incisor or central incisor. We want to have it aesthetically pleasing as we can. So we do bone grafting, we do soft tissue grafting, we use a temporary crown to create an emergence and cervical profile of our tooth. And we're sometimes very happy with the result. But it never stops there, of course, because you must continue to follow up your case and try to keep it healthy. So this case, which I also published in in the clinical textbook, at 1 year post-operative, everything was going very well, and also the X-ray showing very nice result. But in 2 years, this came up, and this is a case of mine. I never show a case of others because I have enough mistakes on my own. And in 2 years, you can see quite a large inflammation around the lateral implant and the lateral tooth, and there's some marginal swelling. But if you look at the teeth beside, you can see that there's some plaque formation around the central incisor and the canine. And the first thing we do is, of course, probe and see if it's perimucositis or peri-implant disease or peri-implantitis. And as we made an X-ray, although there's no visible clinical attachment loss around the implant on the X-ray, you can see that there's a massive bleeding around our tooth. So how do we treat cases like this? Of course, we have the successive treatment after we've done it is based on the cleaning, a lifestyle change of the patient, and a change of supplements. And supplements change is changing from normal toothpaste to a Blue M toothpaste using the mouth rinse and the gel around the soft tissue to maintain it over long term. And this same principle we use around gingivitis, periodontitis, we use also around peri-implant mucositis. So we try to clean the patient. So what's the difference between a tooth and implant? We already have research around this of 1992 of the very nice research on beagle dogs of Berkeley in 1992, and they found that the inflammation residing in the mucosa without bone loss is very similar with gingivitis, and we can do the same kind of treatment for these cases. So what we normally do is we clean the site. I clean the site. We give some additional instruction to our patient. We try to give them a lifestyle change in the way they clean their teeth. So they must try to repeat this every day. And then we supply some active oxygen, some supplements of oral gel around the site. And we ask the patient to repeat this for a few days. So the lifestyle change is very important in our case, because we can tell our patient, you should brush better, but it's not the problem they're not brushing. It's the problem that they don't have it in their mind to brush. It should not be something they should think about, but it should be automatically. So we try to do a lifestyle change, put it in a visible area, try to brush every day at the same time, so it becomes a habit instead of a motivation. Because the motivation dies off, and if you have a habit, you will repeat this every day. So in this case, for example, our result already in 4 weeks, we saw a very clean soft tissue, the bleeding was gone, and when we probed the soft tissue, we probe around less than 3 millimeters. Already we got this result in 4 weeks. So that's what we do around peri-implant mucositis, the use of the additional benefit of the oxygenated products. But it can become worse, of course. And one of the main topics on the peri-implant disease prevention is that we need to keratinize mucosa around our implants. I think that's very important. And if you look at this current case, you might think, okay, we need to do a lot of bone regeneration for this case. We need to place the implants. Well, the implants are already placed in, but we're lacking the soft tissue at this part. We're lacking the keratinized soft tissue. So to ensure around 2 millimeters of keratinized soft tissue labial or buccal around our implants, we need to do a apical repositioned flap from the palate to the buccal area. So we make the flap split thickness. I always rinse out the inside of the implant because I want to get rid of the microflora as much as possible. We connect the healing abutments and then we reposition our flap. But this kind of flap, it's almost an open wound, and this is quite painful for our patients. So what we do is also supply the oral gel to enhance the wound healing of our soft tissue. And we ask our patient to supply this oral gel for around 2 or 3 times a day. So on the one hand side, we get faster wound healing. On the other hand side, there's less pain for our patient, and also the inflammation of the healing goes faster and is less. So this is our result already in 5 days. You can see that there's new keratinized tissue coming up in between the abutments. And this is in 14 days. And after 14 days, we instruct our patient to start brushing the healing abutments again. And in 8 weeks, we got nice, thick, keratinized soft tissue around their healing abutments, where we did not have that before. And if we compare this kind of the initial situation with the situation afterwards, we can see that there is a clear increase of the keratinized soft tissue around our implants, and our patients are now more able to keep their implants clean, which less chance of any inflammation around our implants. But the most difficult part is, of course, the peri-implantitis, and that's the bone loss. And already we've got some experimental peri-implantitis published by the group of Jan Linde in 1994. And I think one of the most important conclusions of their research is that there's no zone of healthy connective tissue around implants when there's bone loss around the bone which is supporting the implant. So if you take a look at the left picture, this is a experimental periodontitis around the tooth. So if you have the apical part of the inflamed connective tissue and the bone part, there's always a zone of healthy connective tissue which is protecting the bone around the tooth. But if we look at the implant part, we see that the apical part of the inflamed connective tissue is already going into the bone instead of there's a healthy connective tissue protecting that bone. And that's why we get a saucer-shaped, a big saucer-shaped bony defect around our implants compared to periodontitis. So it's a very big problem. And already we've got a cumulative interception supportive therapy proposal by Professor Lang in 2000. And as I know, till today, we're still using this same protocol also in the Netherlands to treat our cases around implants. So it's actually always the same around peri-implant disease. We need to do a flap. We need to remove the inflamed connective tissue, and we need to try to clean the implant surface. And according to the bone configuration, we can choose for an implantoplasty, which means that we're going to remove the threads of the implant and to polish it that the patient can clean it better. Or we do guided bone regeneration if we have a 3 or 4 wall defect, but that's not always the case, of course. So if you have a vertical defect, I think it's a better way to do a implantoplasty. So this patient was referred to my office. The implants were not placed by me, but this patient was referred to me because of the peri-implantitis around her implants, mainly at the distal implant. And this is what we mainly see around cases like this. If you open up the flap, you think, well, the bony defect isn't that large, but after you remove all the inflamed connective tissue, the bone loss becomes very sufficient. And since the patient in this case was also a smoker, I decided not to do any guided bone regeneration, but rather to just remove the exposed threads, do the implantoplasty to polish the threads, and just suture everything back. And this is our result, which we can achieve in a short amount of time. And the question is this a treatment outcome that we're happy with? Is it good enough? Well, I think this should be the one of the last resort. Well, the last resort after this we have is, of course, removing the implant and placing new implant. But this is one of the last resorts I have. So we thought of, together with the Blue M company, to come up with a treatment of peri-implant disease, and we call it the topical oral oxygen therapy. It's a non-surgical intervention with oxygen. So we try to do in a few appointments to do a cleaning with a patient, try to remove the inflamed connective tissue, apply the oxygenated gel inside of the sulcus, and to repeat that 4 times every 2 weeks. And we give our patient, of course, instruction of the oral hygiene. We try to change their lifestyle, and we ask them to use also these oxygenated products daily to ensure a faster healing of the soft tissue. So the two directive topical oral oxygen therapy is mainly based on getting as much of oxygen inside of the soft tissue, inside of the sulcus. But because the inflammation is quite severe, we try to repeat this therapy 4 times every 2 weeks. So we're ensuring that the large inflammation around these implants gets to heal a little bit faster. And let me show one case how we use this situation. So one of the situation when we have peri-implant disease, when we probe, is that we get massive bleeding. There's a lot of vascularization, inflammation around peri-implant disease, around this bone loss, around implants, as you can clearly see on this X-ray. So first, our topical oxygen is we give anesthesia, we clean the site, we try to remove inflamed connective tissue non-surgically, and we apply the oxygen gel. We instruct our patient with a lifestyle change and try to get them to use these oxygenated products. And we do this every 2 weeks. So this is the first visit after the second visit after the first time we did the cleaning and gave the initial the cleaning and the lifestyle change and then the oral instruction to our patient. But you can see that the bleeding reduced massively already in 2 weeks. Of course, we still have pockets up to 5-6 millimeters because we're just only in 2 weeks. But in 4 weeks, we can see that the soft tissue is now retracting and is more tight around the implant. So already measly, we went down from a 5 to 6 millimeter pocket up 3 millimeters, distal 5, but you can see there's almost no more bleeding in 4 weeks. But we know that the inflammation is still large. So we try to continue this at 6 weeks, and the pockets is going less and the soft tissue is becoming more tight around the implant. And we do another one in 8 weeks and in 16 weeks, 4 months from the initial situation. We did a checkup and we got the inflamed pockets reduced up to 3 millimeters, and there was almost no more bleeding around these implants. And you can see the difference in already 4 months without doing any surgical protocol, without exposing all the threads, without removing all the threads of the implant. And this is, of course, the bone is not coming up, but we have very non-inflamed situation anymore. So we can monitor this patient for longer term. If there's no bleeding, if there's no clear separation or bleeding on probing, we think we can try to get the situation more stable. So the last case before I end my lecture is what we do with a short movie and what we do around inflammation around implants when there's clear bone loss. Sometimes we still need to do a flap because not every case will respond the same, and that might happen. So we try to have an honest webinar, honest talk around this. So we open up the flap and we remove the inflamed connective tissue. And with a small burr, we try to do the implantoplasty by removing the threads. And once the threads are removed and it's polished, we just apply some oral gel around the implant. And then we suture up the case. Before we close up, we still rinse out the implant. You can also use this oxygen gel inside of the tissue. That's not a problem. You don't get any inflammation around the soft tissue. The soft tissue will react in a very nice way around this oxygenated gel. and then just we replace the crown for our patient because they still want the crown back to chew. I think this is a good option. And if this doesn't work, I think the last resort is to take out the implant, which I don't mind doing because sometimes if it doesn't work, it's better just to remove the implant as we remove teeth when they don't respond to our treatments. We place the gel also inside of the crown and then we suture up. So I think that was my 50 minutes. Is it moving? Yeah, so the oral healthcare goal, which we have in our practice, is to preserve, restore, and very important to maintain everything. So if you have any questions about this topic or anything else, just send me an email to irfan.abbas@gmail.com.